I am currently a core trainee with West Midlands, England, and today I'll just be discussing urinary retention. As you can guess, it's quite common, and if anyone is practicing as a medical doctor, they have encountered some people or somebody with at least one episode of urinary retention. Basically, we're just going to run through a quick background, talk about some clinical scenarios, and talk about evaluation and management as pertains to the current climb I work in. Just before I do that, I'm just going to do a quick anatomy, and basically we can see the sagittal views of both male and female pelvic organs. The female urethra is extremely short, about 4 to 5 centimeters. On the other hand, we have the male urethra as long as 15 to 25 centimeters, with multiple areas of curvature and multiple areas of extrinsic compression. So, of course, as we know, we've got the rectum behind in males. We've also got the rectum behind in females. But also, in addition to that, we've got the vaginal and the uterus just around there. Specifically for the males, we've got the prostate around the neck of the bladder. And as we know, this is a very, very common cause of urinary tract obstruction. So for the urinary retention we're going to talk about today, we'll be focusing on retention beneath the bladder downwards, so from the bladder neck downwards. We're not going to be talking about the kidneys and the ureters. So basically, acute retention is painful, relatively short onset of inability to pass urine, whilst chronic retention is usually painless. Usually they've got long-standing symptoms. They usually have various sort of lower urinary tract symptoms. So they could have frequency, they could have dribbling, nocturia, strangling. They could also actually have had recent or recurrent urinary tract infection. But the key thing with them is that when they come with the inability to pass urine, is usually painless. May be discovered incidentally or as an acute on chronic retention. The incidence, like I said, is quite common. This is a UK study. It's around 3 to 1,000 patients per year. And in almost all the cases you see, you notice that men are much more likely to have urinary tract retention. 10% of men who are lucky enough to live up to 70 to 75 years will at some point have acute urinary retention. Quick summary or quick anatomy or / physiology is just that bladder capacity is about 300 to 400 mils. The physiology of micturition itself is a whole course and is a whole topic. We're not going to finish this if we start discussing about the nitty-gritty of the physiology of micturition. Just the basics for today. Basically via autonomic control, via the parasympathetic and the sympathetic and nervous system. The parasympathetic activation of the parasympathetic system allows urination to occur via contraction of the detrusor and inhibitory and relaxation of the internal urethral sphincter. Because although this is autonomic, we've still got some cortical control and some voluntary control over this. So which is why we have the somatic nerves via the pudendal nerves S2 to S4, and this helps with the voluntary control of the extra urethral sphincter. This is why we don't just go to pass urine every time our stretch receptors from the bladder have activated the parasympathetic system. Just to make it a little bit interesting, before I go ahead to talk about or start discussion, we'll just run through a couple of scenarios. And if I could ask, I'm not going to be creating a poll today, but if you can just input the answers in the message box so we can have an idea as to what is going through our mind. So the first one is a 60-year-old man. It's coming with a history of nocturia, frequency, and poor stream. He's coming to the emergency department with frequent dribbling urine. So his complaint today is that, doctor, I can't seem to stop going to the toilet multiple times. I can go up to 20 times a day, and it's usually just very small amounts coming out at every time. Observations were stable. The heart rate was about 110. On examination, there was a palpable mass in the lower abdomen. We ran a couple of blood tests. Renal function, his eGFR is quite bad, of 30, and his creatinine is acutely raised at 300 micromoles per liter. Just need true or false to the questions, really. You can just say A, B, C, D, E and just enter true or false. So answer true or false. First line investigation is a CT abdomen. He urgently needs a catheter inserted. It should be twerked in 24 hours to 72 days. He may be at risk of diurese and he will benefit from an alpha blocker. If we can get responses in the chat, that would be fine, or that would be appreciated. Or if people want to talk about it, you can mute your microphone and just talk about it. You can make this a little bit interactive. Yeah, answers are coming in. Yeah, just noted. Still on the first scenario, sorry. So we'll just go ahead because of time and just talk about what I think the situation is with this patient. So 60-year-old man is coming with nocturia. There is no pain, which is key in this one, but it's got symptoms that sound like this has been going on for a long while. Before we go ahead to answer the question, I think he's got acute and chronic urinary tract, urinary retention. Chronic because it's painless. 1. 2, acute because I can feel a probable mass in his bladder and he has deranged renal function and he has probably and very significant risk factors for him to be in retention. Questions. The first line investigation will be a CT abdomen. Answer is no. He urgently needs a catheter inserted. That's true. It should be talked in 24 to 77 days. That's false, because apart from it being acute and chronic urinary retention, he's also got a drop in his renal function. So this could actually be a high pressure chronic retention. And for this set of people, you never talk them. So you never remove the catheter. You remove the catheter when there is a definitive management of whatever is causing that obstruction, or 2, you leave them with a catheter forever. And then last one, it may benefit from an alpha blocker because we think the most common cause in men is enlarged prostate. So yes, the Osins family, tamsulosin and all can help this patient. So yeah, Samuel and Abi basically, yeah, almost right there. Second scenario is a 72-year-old lady, nursing home resident with dementia. She presented with severe lower abdominal pain. She's unable to you're unable to ascertain any history from her, and she's been weak and off legs for a few days. Our observations were stable. Answer true or false. An MRI spine may be indicated. Laxatives have a role in the management of this patient. A bladder scan is indicated. She can be talked in 24 to 7 hours. She has chronic urinary retention. Same as before, you could just drop your answers in the chat box, or you can just unmute your microphone and talk about it. Actually, do we think she's in chronic retention or acute retention? Yeah, Samuel is right. I think she's got acute urinary retention, but a couple of things could be causing it, and we may not be sure what is going on with this lady. Abib, thanks for answering. So true to A, true to B, true to C, and false to D and E. Okay. Okay, so just to run through the scenario, 72-year-old lady in bold and underline and everything. When a woman has come in with things that we think and suspect is urinary retention, our cap comes up and we should be very, very, very worried about them. So 70-year-old lady, nursing home resident with dementia, presented with severe lower abdominal pain, unable to ascertain history from her. She's been off legs for a few days and observation was stable. Because we're having a discussion of urinary retention, we can assume this is about urinary retention. Questions are, an MRI spine may be indicated. Yes, because she's female, 1. 2, because she's been off legs for a few days. 3, and because she has lower abdominal pains. She could be an acute urinary retention. And one of the causes, not so common, is caudal equinal syndrome. So yeah, MRI spine may be indicated. That's true. Laxatives have a role in the management of this patient. Nursing home dementia, constipation / fecal impaction is a very embarrassing cause of urinary retention. Embarrassing because when many people miss it, just like egg on your face, really, basically. So yeah, laxatives can have a role in the management of this patient. A bladder scan is indicated appropriately. Yeah, both Habib and Samuel have set falls to she can be twerked in 24 to, I meant 7 days anyway. So 24 to 7 days, 24 hours to 7 days. Yes, she can be twerked. If it's acute urinary retention, you found a cause in the patient, and there is no other indication or reason to keep the catheter in, especially in the females, you can twerk them and give them a chance to pass urine by themselves. And no, she doesn't have chronic urinary retention because she is in pain. Last scenario before we go back to our discussion. So, young chap, 30-year-old man, is coming with inability to pass urine for 24 hours. He's otherwise well. There have been failed attempts by the ED team. His urine dip has showed leukocyte plus. What do we think is going on with these patients before we answer true or false? I seem to have only 2 people on this chart. If you just pop your answers in the message box, or you can unmute your microphone and we can talk about it. Okay, I'm just going to crack on and we can have a discussion later. 30-year-old man, inability to pass urine for 24 hours, is otherwise well, failed attempt by the ED team, urine dip showed leukocyte positive. For the purposes of this discussion, we can assume 1, this chap has acute urinary retention, and 2, he has urethral stricture. So urinary tract infection is the most likely cause of retention in this gentleman. Yeah, he's a young gentleman, definitely not prostate nor enlarged. UTI can be the most likely cause in young people, but we need to also consider the fact that there could be a stricture there, and especially, as I've said, there are failed attempts by the ED team. So someone has tried to pop in a catheter in a young person and they've been unable to put it. Is either there's meatal stenosis, is either there's stricture within the urethra itself. It's very much unlikely to be due to an enlarged prostate. If it's due to a urinary tract infection, is either due to a chronic sexual infection, so you have strictures from gonorrhea and all of that. Unlikely to just be caused by pain, because if it's caused by pain from UTI, catheter is going to go in smoothly. So the multiple failed attempts by the ED team is the, as we would say in Nigeria, banana in the question. Sexual history of screening is important. Yes, for these people, you need to find significant history. Have they had any history of previous sexually transmitted infection that has been treated? Have they had any urethral instrumentation, either medical or for pleasure? So that's true. Flexible cystoscopy is indicated. At some point, this chap has to wee. So we can either do a flexible guided urethral insertion over a guide wire or dilatation as we want to do, or you can insert a cerebral catheter. So it is also indicated. So true. I don't agree urinary tract infection is the most likely cause in this patient. I think he has got a stricture. Thank you, Habib and Samuel. So away from all of the scenarios, so back to our talk. So common causes. So I've just split it. There's so many ways to classify this. When a disease has so many ways to classify it, it means there's so many causes. So it could be obstructive. I like this one. It could be either due to infection or inflammatory. It could be due to medications, or it could be neurological. So obstruction could either be intrinsic or extrinsic, if you want to subclassify that deep. But we can just go through males, common ones, older people. Most common one actually is an enlarged prostate. There could be meatal stenosis, paraphimosis will be painful. Phimosis in people that are uncircumcised with some BXO and some scarring over the meatal opening, and prostatic CA. Not very common in early prostate CA because most times when prostatic CA start outward in the transitional area rather than the central area. So you don't have prostatic obstruction that early. Females, if you remember the picture we showed earlier, so they could have organ prolapse. It could be due to a cyst CA, or it could be due to the rectum falling in. Gravid uterus is a common cause in women and also gynecological masses. In both males and females, compression could be extrinsic. So fecal impaction, GI cancers, bladder stones, bladder cancer, urethral strictures, and foreign bodies. People put all sorts of things into their urethras these days, so don't be surprised. Someone comes with inability to pass urine, and even if they don't volunteer that information themselves, at some point when you do flexible cystoscopy for them, you're going to see it. So infection, this is usually due to pain, spasm. So balanitis, prostatic abscess, and prostatitis is very common, very nasty, very painful. You do a DRE for these patients, they jump off the bed and almost punch you in the face. For women, so acute vulvovaginitis, basically still due to pain and spasms and inflammations. Cystitis, urethritis, and sexually transmitted diseases. Medications that either affect any of the micturition reflex pathways can cause this. So opioids are very common. Anesthetics is very common. Not sure exactly why that happens, but post-surgery, many people go into urinary tract retention. Anticholinergics, like I explained earlier, from the physiology of micturition. Alcohol, benzodiazepines, and detrusor relaxants. So sometimes you've got some ladies coming in because they've had this long-term use of sulfenacin, and they're like, "Oh, I'm unable to pass urine." And you go into their records and you see they've got sulfenacin, they've got mirabegron in their drugs. Basically, yeah, at some point the bladder is going to stop working. Then neurological, this has multiple levels from spinal, peripheral nerves, and all the way up to cortical levels. So you can have spinal cord pathologies. Everyone is always scared of caudal equina, trauma, compression, spinal stenosis, transverse myelitis. Could have some autonomic neuropathies, which can affect any nerve really in the body, so DM and GBS. If you've got questions, you can just pop them into the chat box so I see it as a discussion is ongoing. And you could have stroke, so anything in the brain, like I said, cortical control. So Parkinson's is just a very common cause in older people. Quick run through now as to what we want to do to manage these patients. So starting with acute urinary tract retention. I keep saying infection, sorry. Starting with acute urinary retention, there is one thing that is absolute for them. You're not going to get anything out of them until you pop in the catheter, or until you relieve them of that obstruction. You're meant to follow the ABCD protocol, so make sure you draw off your airway because it is an acute urology emergency, but it's important to recognize a patient that is in urinary retention and relieve them of that retention. There's no point giving them analgesia. There's no point in the real life scenario. They are always screaming in pain. And these are one of the things you suspect in men, women, old or young, screaming in pain, holding their bellies. Scan their bladder if you're not sure and pop in the catheter for them. In the ones that you are able to successfully relieve the obstruction, you can do your history and examination. History, as per the etiology I've just discussed earlier, you can start with their age. Have they been having lower urinary tract symptoms for a long while? Sexual history, medication history, when last they opened their bowels, history of urethral instrumentation, any previous procedures. Have they had their prostate taken out before in the past? And things like that. Have they had previous radiation to their pelvic area? Because urethral strictures after radiation is also very important. After you establish the history, from the history, usually you have an idea of what is the cause in these patients. You can go ahead to examine them. So observations, heart rate is almost always raised because they're in pain. Temperature might be fine. Temperature might be high. They could be having a fever if they think they've got some infection ongoing. And abdominal examinations are quite important. So previous scars, previous symptoms have had recent surgery, so you can see their dressings up there. You need to see if the bladder is palpable, is it painless or painful. That really helps you to determine if it's chronic or acute. It's very important in patients that have come in with retention for us to put a finger into their rectum and examine them. Couple of things to check just by that singular examination: perianal sensation. You're able to see anal wink, or you're able to feel anal wink, check their anal tone. You are able to check and assess the content of the rectum itself. If there's hard rock-like stones in there, you have your diagnosis already. You're able to palpate the prostate and feel for how firm it is. If it's enlarged, is it hard and craggy? You're able to feel the presence of other masses too in there. And also you can able to check for sensation. I think I've said that already. In females and males, go to examine the genitals. You could see some enlarged prolapse. You could see several sort of things that cause obstructions. And a complete neurological examination if you're suspecting caudal equina syndrome. And the bladder scans. Bladder scan is an adjunct, really. Most times, by the time you reach the end of your examination, you know if they have retention or not. And the bladder scan sometimes is usually to just for completeness sake. After you've made a diagnosis, you've put in the catheter, always remember, especially also for exams, there's no point talking about everything you're going to do. There's no point talking about the full A to E assessment if you've not mentioned your need, or if you've not mentioned the need to please put in a catheter or try to relieve the obstruction in these patients. Investigations, urine dipstick. In older people, urine dipstick is more or less useless, might be much more useful in younger people. Send off urine cultures if you're suspecting infection, even in the place of a negative dipstick. Full blood counts, useful to check for low HB if you're suspecting a cancer. Very useful to check for what the white cell count is if you're suspecting an infection. Use and yeast are very important because you need to know what the renal function is like. And clotting has been put there as an adjunct if eventually you're going to need to do some interventions like suprapubic catheter insertion. Imaging, ultrasound, kidneys, ureters, and bladder, very important in patients with chronic retention with deranged renal function. It gives us a diagnosis of high pressure chronic retention, and cross-sectional imaging eventually, because you want to check for in patients that need it. So patients that need it will be older people you're suspecting the possibility of other masses, people that are known to have prostate cancer, you're checking for other spread or metastasis, people that have really weird symptoms and you don't seem to understand why exactly they've got retention. So you can cross-section their abdomen and pelvis to see if you find anything there. So that's the investigation, really. Just going to wait for the slide to come up. I think I've talked about the management in a very brief one. So acute retention, put in a catheter, most common catheters, 14F or 16F, straight in, monitor the residual urine to make sure they're not diuresing, because if they are in acute retention and they passed more than 1 liter residual straight away, or they've passed more than 200 mils over consecutive 2 to 3 hours, they are at risk of post-obstructive diuresis, and you need to keep them in and replace their fluid and monitor them so they don't go into kidney failure. Identify and treat the cause. So always wise to identify and treat the cause. If it's acute urinary retention, both the American and the European guidelines have said you need to plan for a catheter removal. It all depends on what you think the cause is, but within 24 to 7 days, you should plan to remove it. In older men with very high risk of BPA, you can palpate their prostate. You can start them on tamsulosin, give a chance for tamsulosin to work, and depending on your local guidelines, you can remove the catheter between 4 days and up to 2 weeks. So basically, tamsulosin is just to help relax the bladder neck and give them a higher chance of passing to work. Acute urinary retention with no diuresing and there's an identifiable cause, we should always plan for catheter removal, usually before they leave the hospital. And when we have chronic retention, most people with chronic retention either come in through the clinics, 1, 2, they come in incidentally, so they've just done random blood tests by their GPs or their family doctors, and they found out that their kidney function has dropped. And the next thing usually will be that, oh, you need to go do an ultrasound. And they go ahead to do an ultrasound, and the ultrasound comes with massive hydronephrosis. They've got about 1 liter size bladder in them, and they're fine. They're talking to you, no problem whatsoever. That's one group of people. The other group will be those with no symptoms of pain, but they've just come with frequency because they're having overflow incontinence. Those are the other group. And the last group are the ones that come with acute or chronic retention. So older men, they've been retaining for a while, their bladder has expanded and is big and it's just lax, and at some point they need to go. So they come with that. Patients with high pressure chronic retention. This is very useful, especially for our medical colleagues. So a patient has come and they've got established renal failure and they came with retention. It means their bladder is back pressuring into their kidneys and is ballooning up their kidneys. If it continues like that, they're going to go into chronic kidney failure. So the key or the goal here is to keep the drainage ongoing, especially older people. So we cannot talk them. So we cannot remove that catheter unless there's a plan for treatment. So for example, if a 70-year-old man has come, like the man in our scenario, had come with what he has and his renal function is deranged, we put in a catheter. We observe that his renal function is improving. After we've done that, we need to plan for a couple of things. If it's fit for surgery, we need to plan him for a TURP. If it's not fit for surgery, the options are to leave the long-term catheter in place. That's one. Or some people prefer to have a suprapubic catheter. But the point and the goal here is that for high pressure chronic retention, that is retention with deranged renal function, we do not work them. Chronic retention, no derangement in renal function, you need to plan for catheter depending on the cause. If there's a mass, we need to treat the mass. If it's because of constipation, we need to deal with that. But in most people, most men, it is usually due to enlarged prostate. There's another class or another form, which is a whole specialty on itself. It's called neurogenic bladder. So these guys either have spastic bladder or they have dilated bladder that is just like a balloon. Treatment can be discussed in a different topic, as a different topic entirely, really. I think the next slide will just be a few practical tips on difficult catheterization. Currently working urology, so for the short time, I've seen lots of things. Lot of things can be done, especially in patients. No one likes to be called for a catheter to be changed, but it has to be done. So in males, most common cause is an enlarged prostate or a stricture, really. And one of the most common things when people try to put in the catheter is that they're really not straightening the penis long enough. As you can see on the curve here, the penis has so many curvatures. And if you're just timid with the penis and not grabbing it and pulling it up straight up like you want to pull it up towards the roof, that's the trick people say. Just straighten the penis 45 degrees to the body just because you want a very nice, smooth angle. But the thing is that I don't know if you can see my arrows. Hopefully you can. But if you can't, if you look at the bladder neck in this picture, the prostate sometimes is usually so enlarged and so high that when you put it in at that angle, you meet a resistance. So if the obstruction is at the prostate, you meet very large resistance there. The point is not to jam it in there. If you keep jamming it towards that angle, you're going to form a false passage downward there, and that becomes a trouble. You feel a resistance, so drop the penis slowly, like you're dropping it back down alongside to the body. This kind of brings out the angle and straighten it up, because if you remember the curvature, it kind of curves upwards as it's going into the bladder. And usually you can just slowly twist a non-curved tip catheter so it goes in through the obstruction. If you're still having difficulty in it, it depends on your local practice. Some people usually have these latex, very soft catheters. That might not work. You might need to find a silicone catheter, which is stronger and a little bit much more rigid. For people that we suspect that, oh, this is most likely due to a prostate enlargement, you can go slightly higher up in size, because it's basically you need something to push through. If that is too small, you might need something really stiffer and stronger to push through the prostate, and that usually helps. You can put double lubrication because that helps to relax the patient. One, and if the patient is much more relaxed, you have a higher chance of that external urethral sphincter relaxing enough for you to navigate through a difficult prostate. If the obstruction is due to a stricture, as was the case in the gentleman we saw earlier, and we discussed earlier, you usually just feel it just going through a very short tip. Usually stops at the bulbar urethra, never reaches that angle down towards the prostate. Clearly something is going on there. Also, try not to use force. Never force a catheter through a penis, because you're most likely going to cause more harm than good. You can go in through a smaller size catheter and see if you can go in through the stricture. That's for males. In females, this is basically just 4 to 5 centimeters. The problem is not usually the urethra. The problem is usually entrance to the urethra. Most common problem is that the patient is quite on the big side and you can't really properly assess the vulva to look for the urethra. And this is usually just helped. This is usually just countered by getting much more people around to help you and getting the patient more to cooperate to, so that you can probably part the vulva and actually see the urethra opening. The cystoscopy, you can also block the whole thing so you don't see anything. And in some older patients, especially older ladies that have some vaginal atrophy, the position of the urethral meatus may have been distorted in such a way that it looks to be appearing in the wall of the anterior vaginal. So, sorry, in the anterior vaginal wall. So you're like, oh, you can't find the urethra opening, but it's just down there. And meatal stenosis. And also in some patients that have had radiation to the pelvis, they could have some urethral stricture, even though it's short in female, and this could also affect them. So basically for males, you need some adjusting, and always call for help. If you've tried to put in a catheter twice and it's not going through, just call for help for somebody. Call the urologist. They've got lots of toys to play with. And one of the most common toys is the inserting the catheters under guidance. So you put a flexible cystoscopy. I think that was the next slide. So you put a flexible cystoscope through that, and you can view everything that is going on. And once you get into the bladder successfully, there are several ports through the cystoscope through which you can pass this small looking round thing here called the guide wire. And this guide wire goes in through there. Once the guide wire is in, we're sure the guide wire is in the bladder. We take out the cystoscope and pass a catheter through that guide wire. Now we are sure that we're not going to cause a false passage because we know the guide wire is in the bladder, and you can apply a little bit of more force, and this helps you, just gives you the confidence to navigate that into the bladder. Another thing we can do is the use of the coude tip. So there are different types of curved tips we can use. Just when you remember the angle of curvature of the prostate, so there's a taper tip which goes through there, then the olive tip and the popular Tiemann tip catheter. All of these are just mechanical ways to go through an enlarged prostate. So Tiemann's tip, flexible guided cystoscopy. You can do a bedside urethral dilatation in patients you can see some strictures in if it allows. There are hydrophilic S dilators through which you can pass through the urethra bedside really and try to help them relieve this obstruction. And in people which all of that has failed and without a contraindication, a cerebral catheter is actually easier to manage than a urethral catheter. Even for patients who have been advised to go on long-term catheter, an SPC might actually be a better option for them. And it's easy to change. The only problem is that the first change should be done by a urologist, and any change afterwards, this is usually after 3 months after you've had the first change, anybody can change a catheter as long as the tract has not closed. And the tract closes really quickly. You'll be shocked. Within 8 hours of an SPC falling off, the tract usually is closed already. And we need to go to theater to do a different one. So basically, that's the end of a very short discussion on urinary retention. Things to take away: acute urinary retention, most common cause in men is, in older men or men altogether, is an enlarged prostate. In females, we need to be careful and we need to think about other causes. We need to think about possibility of caudal equina syndrome. We need to think about constipation. We need to think about radiation, and we need to think about neurogenic causes. Chronic urinary retention with deranged renal function, plus or minus hydronephrosis on ultrasound, the catheter should not be taken off. And for patients with simple acute urinary retention, it is the aim to get them catheter free as quick as possible. This is usually by identifying and treating the cause, giving them medications that gives them a higher chance of passing TWOC when they're eventually TWOC'd, and also trying to find definitive management for them. I would not go through the scenario questions again. I will just leave it here so we can have a look at it and people can ask questions, especially as to the ones they don't agree with, and see how we can discuss about it. So if you've got any questions for me, please kindly ask now or drop it in the chat in the chat box. I'm not sure if that was fast paced or that was just. Any questions, guys? Okay, so right in the absence of any question, I would ask my colleague to send out the feedback form so we can have the feedback completed, improve on our sessions. Okay, looks like we've got some, and we can. I think the next meeting is about in 2 weeks' times, and you can also drop suggestions on topics you would like to cover. So we are giving or delivering topics and teachings appropriate for the level of people attending this. I think the feedback is open. So thank you, everyone. Thanks for attending. Have a lovely evening.